PCA pump. This is used when you want to be giving your patient an uninterrupted infusion of opioids. You don't want the person to have to wait every 4 hours for the nurse to be free to give them their pain meds. You want to give them a little bit of control over the situation. So it can be used when you want a continuous infusion of opioids, or you can program it so the patient can self-administer by pushing the control button. And it can do both. You can get a very small hourly rate called a basal rate, very small amounts, but the person can push the button and get an extra bit of analgesia when they feel like they need it. And you can calibrate these pumps to order a particular dosage and a particular frequency. And they're designed to have a particular ratio. So like with morphine, 1 milliliter will contain 1 milligram. So it's a 1-to-1. With Demerol, it's 10-to-1. 10 milligrams in a milliliter because it's not as strong. I believe hydromorphone or Dilaudid is also 1-to-1. But you can have a very small amount going in with bolus doses that the patient gets by pushing the button. You can do only patient administration or only a basal rate. It just kind of depends. And the physician will write the orders. They'll usually do a loading dose. They'll order a basal rate if desired. They'll order an amount to be given by patient control, and they'll set how often the person or the patient can push that button. I've seen it every 6 minutes. I've seen it every 10 minutes. And then the nurse's job is every 4 hours to go in to write down all the numbers that show up on the pump, to clear the pump, and to start it over again for the next 4 hours. And part of the patient's duties is to teach the family who's in the room that they should not push the button themselves. There should be a sign to that effect. The whole idea of PCA, patient-controlled analgesia, is the patient needs to be awake and alert enough to know when they need pain medicine. If they're too sleepy to know that they can find their button and push it, then they've probably got too much med on board and they don't need any more. But what'll happen, you get a bunch of, well-meaning loved ones sitting around the person, and every time the person moves a little, they groan because they're hurting. They're still perceiving pain to a certain amount. And the family will reach over and push the button. And I have seen well-meaning families overdose their family members. So what you want to do is train them. If your family member expresses discomfort, give them the button and instruct them to push the button themselves. If they're awake and alert enough to do that, they're probably fine. If they're too sleepy to comprehend the directions, they probably do not need it. So when it comes to drug interactions with various opioids, you want to warn people about not combining CNS suppressants. That's where we see a lot of these tragic opioid overdoses now, is people are not only taking opioids, but they're mixing them with benzodiazepines, barbiturates, alcohol, and they're creating too much central nervous system suppressant. The patient loses their cough reflex, they decrease their ability to breathe, and they wake up dead. So you also will sometimes see stimulants working against the opioids. So they're going to decrease the effects. So a person takes their pain medicine, but then they also light up a cigarette and drink a cup of coffee, and they may not realize that those are considered stimulants and can decrease the effectiveness of the pain med. The assessment of pain should take place within 30 minutes to an hour. after a pain med is given. This varies depending on the facility protocol. So you want to check the pain level before the pain med, administer the pain med, and then come and reevaluate or reassess or evaluate 30 minutes to an hour later and record. And JCAHO usually will look at charts to make sure that pain is checked before medication and then is reevaluated after the medication. On pages 216, you've got some safety boxes and some lifespan considerations in your textbook, so make sure you read those. Read the patient teaching on page 217 and remember the side effects of decreased cough, constipation. Tell your patient, don't drive. It's not a good idea on opioids. And the risk of orthostatic hypotension is there also, especially with the elderly, and opioids will make you a falls risk. Let's talk about narcotic antagonists. These are drugs that occupy the receptors, and rather than creating the response from the opioid receptor, it blocks the response from the opioid receptor. And we would have to be asleep for the past 10 years not to recognize the prevalence of the narcotic antagonists among us. Excuse me. All first responders now have a supply of Narcan on hand. Many family members have been trained to give Narcan because their loved ones have suffered overdoses. Some states even will provide narcotic antagonists to their librarians. They'll keep that locked up because people tend to go hang out at libraries because it's warm or cool, depending on the time of year. It's clean. There are restroom facilities. And if you've got a drug user who doesn't want to be out on the street, many times they'll go in a library, find a quiet corner, and overdose. And so librarians have been known to save a life finding a patron that has overdosed, and they reverse that overdose long enough for the ambulance to get there. So the narcotic antagonists are discussed on page 215, and these are used for postoperative opioid depression, and occasionally even a clinical dose of opioid will make the person a little bit too sleepy, and they don't really wake up and respond the way they're supposed to in the recovery room. So it'll be reversed with Narcan or a similar narcotic antagonist, and it's probably most recognized by all the news reports about people being brought back after overdose. What it does is it occupies the narcotic receptor and displaces that opioid and makes the person begin to breathe more freely. They regain that cough reflex, their blood pressure goes up, their pulse goes up, and the person wakes up and recovers from this overdose. Now, we have to remember that narcotic antagonists have a shorter duration of action than opioids. So you can't just shoot a person up with Narcan or squirt it up their nose and just take off. They have to continue to be monitored. So a librarian finds somebody who has overdosed, slow pulse, not really responding. He or she takes the Narcan, administers it. They can't just walk back to their desk and get back to whatever they were doing. They have to call 911. They have to seek help for this person, and the care needs to be continued beyond the community. And those of you who work in ERs, I mean, I know you see this all the time. Students have talked about working in ERs and seeing the same patient come back 2 or 3 times in one weekend with narcotic overdoses and being brought back. A nurse has to continue to watch the heart rate, blood pressure, and respirations of someone who has had Narcan or a similar drug used on them until the opioid is completely out of their system and they wake up. We're probably very familiar with the administration of Suboxone, And this is a narcotic antagonist, naloxone, and a very mild opioid agonist-antagonist called buprenorphine. So the buprenorphine is to keep those receptors partially occupied so the person doesn't experience such a severe withdrawal symptom, plus that naloxone blocks other receptors and helps the person to kick their habit a little bit more easily, in theory. All right, we'll stop there before we move on to agonist-antagonist drugs.